terminal ileal tuberculosis considerations and management.
Firstly, I just want to thank everybody for joining in this morning. It's so lovely to see everybody's, faces. And, I can say the one thing about this pandemic that has been, the only real silver lining is the fact that we have really shifted to this sort of virtual connectivity and had these new avenues to, really see each other a little bit more and connect as surgeons. And I definitely want to thank David and the Cleveland Clinic for the opportunity to just be involved and meet with you guys all this morning. We are going to talk about a pretty interesting case. First, I do just want to disclose that I am the site PI for clinical trial sponsored by Tagenics. So this case is a 23-year-old female who presented over the Christmas holiday. She was in town visiting from New York from her family. She started feeling initially pretty poorly around the summer, where she was just having these recurrent sore throats, never had any other past medical issues. And at that time, she had gone to multiple urgent cares, gotten steroids, and was diagnosed with pulmonary and laryngeal TB. It's very unusual. We weren't really sure why she had this tuberculosis. She had a negative HIV test, but a normal CD4. And she came in essentially in extremis. She also had a past medical history for kidney stones, so they were concerned for urosepsis. But at that time, she had essentially been in her usual state of health on quadruple therapy, responding well to therapy. But she had acute onset abdominal pain, distension, nausea, and vomiting. She said it had occurred probably about 12 hours prior to presentation. She is 23, so obviously could amount quite the response. But when she came in, she was afebrile, and her heart rate was up to 194. It was a very profound sinus tachycardia. She was hypotensive. She was tachypnic and setting 93% on room air. And you can see here, this is just the trend of her vital signs with these pretty significant hemodynamic shifts.
194. Go back to that slide for 1 second for me, Dr. Smith.
Yeah, absolutely.
So 194 is pretty impressive for sinus. I mean, that just, like you said, goes to show you the amount or the response that she can mount from being a young, healthy female. So absolutely. I do want to stop here for a sec. And Dr. Stackhouse is one of our premier chief residents. And so I talk to you about, take the title of the talk, but take that out of it. You're going down to the ED, you're getting called. This patient has acute onset of abdominal pain. She's hemodynamically unstable in the sense of her tachycardia. Talk to me about some general things you're thinking about as you're getting ready, not only to manage these types of patients on your own. You might be asked something like this as a scenario for a board exam. What are the types of things that you're thinking about? What do you want to obtain? What's your plan? Take me a little bit through that.
I think the first thing you'd start with is resuscitation. So, you'd have good access given that she's hypotensive. You'd want to start some IV fluid resuscitation, probably until you know what's going on, maybe start some broad spectrum antibiotics. And then definitely you want to make sure she has respiratory support too, if she's starting to desat and she's a young woman. And then you want to start thinking about imaging. In this case, probably a CT, chest, abdomen, pelvis. Though if she decompensates more quickly, you could start with a chest X-ray and a KUV.
Excellent. Yeah, I think you're dealing with someone who you have concern for sepsis, and so it's all the the sepsis alerts that we have. There are protocols that are instituted to help guide us. Exactly right. Make sure you got your IV access in. Right. You have you're drawing labs, including a lactate, which is one of the things that we use and can trend to not only guide the state of the sepsis, but the state of your resuscitation. Start IV fluids, broad spectrum antibiotics after you draw your cultures, right? Your blood cultures, and if there's any concern for urinary infection, urine cultures, chest X-ray, like you mentioned, and then start narrowing down your source of sepsis, which then takes into account the patient's medical history, and taking the fact that she has got TB history, kidney stones, etc. Anything else I'm missing there, Dr. Smith?
No, that's great, Dr. Stackhouse. Thanks for your contribution. The only thing to add is that 194, like Dr. Rosen says, really high. So she was also given some adenosine just to make sure there wasn't some SVT or even, an atrial arrhythmia, which is unlikely in that age group. But it was, in fact, sinus tachycardia just from profound sepsis. So she got some baseline labs, which showed a white count of 3. Her baseline is normal. Her lactate was 4.2, just suggestive of some dehydration. Her bicarbonate was 18. Her creatinine was 0.7, up from a baseline of 0.3. And just as suggested, she got 5 liters of fluid immediately on presentation. A respiratory panel, including a COVID, was drawn, which was negative. She got blood cultures. A urine culture was also sent off, and a UA, which really was unremarkable. She had a right upper quadrant ultrasound, and they ordered that. And then they started vancomycin, cefepime, and Flagyl. And then she unfortunately had a contrast allergy. So, and they were also primarily concerned for pyelonephritis, given her history of renal stones and her general response to her tuberculosis treatment. They felt that this was more likely related to just something unrelated. So they got this non-contrasted CT. All right, so I'm going to just sort of slowly scroll through this here. You can go on the lung windows. She really has very minimal changes associated with her tuberculosis. There's no significant free air. You can see she has very little intra-abdominal fat, and given the amount of the lack of contrast, it is challenging to delineate what exactly is going on in here. But there's some clear mesenteric edema. There's no obvious free air, and she has stool and gastro colon, as well as some pelvic ascites. So they read this as mildly dilated small bowel loops with air fluid levels, and they felt that it was either ileus versus small bowel obstruction, but they couldn't really tell. And the scan was reviewed with radiology multiple times, and they really felt that it favored more ileus. And then it also fit her clinical picture because she said it was very acute onset. She had never really had any other surgeries or anything to explain acute onset obstruction, and she just started with generalized malaise. She also had increased in pelvic ascites, and they couldn't rule out any peritoneal TB with a lack of IV contrast. So this unfortunate girl presented around 8 p.m. and they were just treating her conservatively, and then they finally talked to the infectious disease team in the morning, and that's when they thought, why don't we just get colorectal surgery involved? So I was doing a appendectomy that day because it was the Christmas holiday, and I get this call. So at around 2 p.m., I go down and see her. At that point, she was afebrile. Their resuscitation efforts were successful, and her heart rate was 120. Blood pressure was stable. She was on room air at 98%. So definitely seems like she had responded well and looked pretty good. At that point, she was soft and she was very distended, but she was minimally tender and absolutely non-peritoneal. Just like, yeah, I'm not really sure why my belly is hurting. I don't feel great. So given this read of the small bowel loops, air fluid levels, and then unable to rule out ileus versus obstruction, and the discussion with her ID doctor and sort of how complicated her course was, I was just, wondering, Dave, what are your thoughts? Or if you want to open up to the audience, like how would you guys sort of approach her?
Yeah, that's perfect. So let me go to Dr. Cantors, my partners at main campus. This would be a classic one for you to get, a very confusing one, lots of stuff early on in your career, classic case. So she's better now. And you've got this weird read, the CT scan, you can't really see much. Where would you go from here? Do you just go straight to the operating room because, well, this is weird and there's some TB and they say maybe there's peritoneal TB involved? You sit on her and wait. What are your thoughts here, Dr. Kent?
Sounds like a classic Coors ACS kind of consult. Although usually it's ischemic colitis at this point of the year. So when you went to see her, I guess I've never seen abdominal TB myself, but if she's increasingly distended, certainly repeating a KUB, but this comment on the CT read of, cannot rule out peritoneal TB due to lack of IV contrast. I'd have a conversation probably with ID and radiology of a potential gain in repeating scan, as much as you don't want to overexpose her to radiation. But if she only has a relative rising creatinine to 0.7, and there's even a question of, is there true nephrotoxic effect of IV contrast versus just transient creatinine rise? Would there be a benefit to repeating imaging? Sounds like she's relatively stable. I don't think rushing to the operating room necessarily makes sense. But then the other question, I don't know, one thing that comes to mind is whether or not there's an indication for a colonoscopy. You could possibly intubate the TI. Otherwise, continuing to monitor. I feel like this would be a big conversation with ID and kind of what a natural course of a possible abdominal TB presentation would look like.
Yeah, it certainly is not something typical that we see. Before we get back to it, Dr. Baer, are you our Fairview resident attending expert on abdominal TB? Do you have anything else to add? Any thoughts? This is something you've come across?
I certainly have not come across this just yet. But I think with that resuscitation, I agree about kind of really sitting down with everyone involved in our care to talk about next steps. I don't think that there's a need to rush into the abdomen. I do think if a patient has persistent symptoms or worsening symptoms, there is a role for diagnostic laparoscopy in trying to figure out what's going on, especially if we can't obtain adequate imaging to help.
Great. There's a question in the chat. Someone asked, what about tapping or fluid to look for acid-fast bacilli? I think that's a great thought. I don't see much fluid really of a target of a goal here on the CT scan to get. I think that's a really good thought. Dr. Smith, what are your thoughts on that?
Yeah, one thing I'll throw at you there is that, I have taken care of a variety of TB cases on my trips to India pre-COVID over the years, and they look a lot like Crohn's. The small bowel TB act a lot like our small bowel Crohn's. And so you've got to adjust your thinking and say, okay, I know this is weird because we don't see TB in the US, but it basically clinically behaves the same. So the way you would treat a Crohn's patient with small bowel obstruction from perhaps multiple strictures is maybe the same way you treat TB. The advantage we have that I'd not yet seen in the Indian centers where I operated on these patients is rapid access to MR. And there might be a way you could delineate both the small bowel and any peritoneal involvement with MR scanning if that's available.
It's all excellent discussion, and we really did all of that. So her exam was definitely reassuring to me, and I spoke with her ID doctor, and he had felt that she also had some just non-specific GI complaints really over the last, I'd say 10 years, just I think like most young women can have, sort of IBS type symptoms every once in a while, nothing too concerning, but there was a question of overlap of Crohn's disease in her as well. And I really was very unclear about what the etiology of this was. There is some pelvic fluid, as a caveat, that acid-fast staining or cultures can take a while to grow out, and even the staining at that time of day over the holidays, I think would have been challenging to do. We're also in a small community hospital at the outside, so just sort of delays in care. So given the fact that she was sick, and at this point we really had only abdominal source to go off after. While her UA was negative, my primary working diagnosis was maybe that she had some urosepsis and maybe some and she had ischemic colitis or something like that, or some mesenteric ischemia, non-occlusive mesenteric ischemia from just shock, and that was driving an ileus. But I really did feel that having IV contrast to just look for the viability of the bowel and see if there was any transition points in this represented bowel obstruction would be helpful. Unfortunately, again, she had this contrast allergy, so we did do a 5-hour prep, but we had the benefit that she was very stable. So we repeated her scan as Dr. Cantor suggested that we should, with IV contrast. Here, you can scroll down, you see there's this large volume ascites, but unfortunately you can see she had perforated. So she has these foci of free air. She does have some dilated bowel, but not, too excessively so. And then when you come down to your to the mid-abdomen, there's an area that does appear strictured right here. And another area that they felt this was also a stricture. And then this area I will show you on the next slide, but you can see a luminal defect there that they think is a perforation, the focus of perforation. And there's her large bladder. So this right here, I don't know if you guys can appreciate that. There's all this hyper enhancing mucosa, and then there's this antimesenteric perforation. So given this diagnosis, it was very clear that, or this CT findings, it was very clear she needed to go to the operating room at that point. Thankfully, she was able to be resuscitated up, and we got her transferred to our main hospital, and we took her back to the operating room in a stable fashion, thankfully.
So let me, before you tell us about what you found,
sure.
In terms of approach, do you go, what are your thoughts on straight open versus laparoscopic? There's a comment in the chat. I don't know who says there's no name associated, but talking about concerns for laparoscopy spreading TB into the air. Is, in someone like this with dilated bowel, maybe there's not room anyway, and it's a moot point. But I actually don't know if that's true, if that is a concern. I don't know if you know, or Dr. Wexner, if you've come across that in terms of laparoscopy.
Well, at this point, she had been on quadruple therapy for probably 4 or 6 months. So the feeling was she actually wasn't actively shedding disease because she had radiographically responded. I'm not sure how that when you are talking about CO2 insufflation, if it's the same amount of what she would be shedding from her lungs. But technically it would not have been possible given the amount of bowel dilation that she had. And just also the concern with underlying immunodeficiency and really needing to wash out her belly really well. We decided to choose a open approach. But Dr. Wexner, I would love to hear your thoughts.
Yeah, I don't see where you'd put a camera here, and from having trained with us, Radek, I'll put a scope in pretty much anything, but there's no room here. I don't know where you would put it. Plus, she's septic. I mean, her pulse rate's almost 200. I don't think I'd spend a whole lot of time adding a laparoscopy that might result in a conversion. I think you made the right decision to go straight to laparotomy.
Great, thank you.
In the ER, I truly had no idea what I was going to find. There's a lot of wide variety of case reports that talk about the different types of intestinal tuberculosis and how it can manifest, and people can get frozen abdomens with just a very profound immune response. There are people who can have, what I thought was going to happen here was that she had multifocal strictures. That's clearly what the CT had alluded to. And then essentially a closed loop obstruction with perforations. But surprisingly enough, that's really not what we found. You can see that, for the amount of extremis that she was in, she really has very little serositis. She had a minimal amount of murky fluid in the abdomen that was all suction free, and just some ascites that was contaminated, but nothing, too badly. And then these vicryls are marking the areas that she was perforated. I just started running the bowel and whip stitched it. She definitely had a proximal area obstruction, but then this was the pretty classic finding where she had these like patches of granulation tissue and then these antimesenteric perforations, and there were these tiny little holes. And again, you really can appreciate there's a really a paucity of inflammatory changes. And again, I think that probably reflects an underlying immunodeficiency. While her CD4 was low, the underlying thought was either she has a primary immunodeficiency leading to tuberculosis, or she had myelosuppression associated with severe tuberculosis, and we weren't exactly sure what was going on with her. And as a backstory, this 23-year-old girl is an investment banker in Goldman Sachs. She was, very, very high achieving young girl from St. Louis who went off to college and had just gotten her first job. She had no HIV exposure, nothing really else to suggest why she shouldn't have gotten this. So the working theory of she was immunosuppressed and then got TB, even though the first, couple decades of her life were relatively asymptomatic, was really what we thought was going on. But again, this was the most unusual thing. I did not see the findings. I mean, maybe you can see a bit of creeping fat here on the mesentery, but overall the mesentery was quite soft, and everything really did appear just very strange with large patches of granulation, and then almost like someone took a hole punch and just took out the antimesenteric border of the small intestines. So here you can just see, like, here's this first picture, and then on this one, two just like punctate holes. Here's another one, and another one. And then this actually is the area of stricturing, and then everything up here is actually her proximally dilated small intestines. So just highly unusual. There was, she's very lucky because she ended up having a lot of small intestines, but what we ended up doing is actually having to resect about 120 centimeters of terminal ileum that involved all of these chronic changes and had areas of perforation. There was the last probably 30 centimeters of ileum that appeared inflamed, like maybe one of these loops, but did not have any of these big granulation patches. So I was thinking about trying to save it by just having it defunctionalized and hoping that maybe eventually when she was fully eradicated and maybe more immunocompensated with some IVIG or primary treatment of her underlying disease, then I thought that perhaps we could maybe keep her valve and give her more bowel. But during the washout and just, getting hemostasis, we looked down and it had not been perforated. We really interrogated it. And then we looked down and there was a little hole there. So it was honestly so strange what we were seeing. So we ended up taking it all the way back to the cecum. So, post-operatively, she did well. She actually has about 900 mLs out of her ileostomy a day. We left her skin open and then put a wound vac on at the time of the operation. And she was recovering well from that standpoint. And her pathology came back as extensive transmural non-caseating granulomatous ileitis. She did have strictures associated. She had a positive margin on the distal side or the proximal side, but the infectious disease doctors were not at all concerned about that. The great news is that she did not grow out any acid-fast bacilli. So the feeling probably was that she had fully eradicated TB. Her immune system was starting to pick back up, and then she got some sort of microvasculitis within the ileum related to her immune system, and that caused these multifocal perforations. And there was, like I said, no evidence of inflammatory bowel disease. However, that was definitely a concern of ours.
Given the general weirdness of the case, of
Yeah.
the disease, the unfamiliarity of it, was there anything that you saw? Did you ever consider, given how things looked intraoperatively, saying, you know what, maybe we want a second look just to make sure nothing further develops, leave her open for 24 to 40 hours and come back? And that obviously has some downsides, an increased rate of hernia, interatmospheric fistula, all those types of things. So you don't want to just do that willy-nilly. But what are your thoughts there?
Well, I would say there was really actually a very sharp transition. The area above the level of the stricture could not have looked any normal, and the area below the stricture looked just so friable and ratty. And honestly, I'm not really sure what the right thing is. I will say in the case reports that I've seen, if there is a downside where you get sort of reactive TB, in the case reports that I have read, that has been an issue. There is a high associated morbidity with these patients because they come in very much like this, doing fine, and then all of a sudden have come in perforated or completely obstructed with a closed loop and just sort of fall off. For her, I felt really confident, and I also knew, at that time she was resuscitated really well. She was able to transition to the floor, and she's young and robust. So while it wouldn't be ideal, we could always bring her back to the OR, and as you suggested, reduce that morbidity of keeping her belly open and sort of getting her more toward a functional recovery, which I felt was more likely than not.
Great.
So she was discharged to home on the endostomy, and she's on quadruple therapy. Initially, they were thinking that she would need IV because they were concerned about her absorption, but she actually has done quite well from that standpoint. So she's on PO. We are waiting for the NIH immunodeficiency panel, and we had the immunologist see her, and they did give her some IVIG throughout this because they thought that she likely had some underlying issue with her immune system, and her IVIG levels were low. And, I was planning for reversal in 6 months, but again, the clinical course of this and sort of the actual way that this typically plays out is unclear. And so I think I'll just treat her like normal. The only thing to add is at the time of her operation, she had no real evidence of peritoneal tuberculosis. There was some nodularity on her peritoneum that was biopsied, and it was just ended up being fibroadipose tissue.
Excellent. Yeah, there's one more comment in the chat from our mystery chatter saying that just commenting on, obviously for this patient, but of historical note, the original strictureplasty was done on TB small bowel, tuberculosis small bowel strictures. Yeah, Dr. Smith and I were talking about that. And I think that goes along with what Dr. Wexner was saying, how this behaves and treated a lot like Crohn's. Any other thoughts, Dr. Wexner, on that?
Yeah, Katerina originally described that, it was his name of the author who wrote about that for TB, and then it was first at Oxford for Crohn's by Jewel and Lee. So it is thinking the same. And so what Dr. Smith found in terms of the acute perforation, again, it's like Crohn's, where somebody has an acute setting of perforation, but if you see them in the chronic setting, and she mentioned it, as they get treated, they get fibrotic. So I think the record number of strictureplasties I'd ever done was not in Crohn's, was in TB, where you just go into the stricture after stricture after stricture, and you don't want to resect the whole small bowel, and they're very fibrotic, and they're the same. And you're right, they have the management is basically the same, but if you get unlucky, you get the perforations instead, because you end up with a stoma. If you're lucky, you get the fibrotic strictures, and you go in and you do the strictureplasties. But you kind of have to think the same in terms of medical management versus surgery, and when you're in surgery, how you manage what you find. So I think it was very well managed. I'm not sure what to do with the microscopic positive margin. That I don't know. Even in Crohn's, that's debated depending on what paper you find. So I don't know what you came across, Dr. Smith, the significance of that margin, because in Crohn's you can find papers in both directions as long as the margin is grossly negative or if it's microscopically negative. But what do you think about that one?
So the feeling was that probably was clinically irrelevant, and that maybe it was just some sympathetic inflammation from everything going on. But that said, I think, again, it felt very grossly abnormal, the areas that were diseased and the area that was not diseased. But when I take down her ileostomy, then certainly we can assess it at that time. Alternatively, because it was a small bowel margin, we can also just culture her proximal bowel and see if there's anything there, or biopsy that and see if we can grow out any AFB. But common things being common, she is just recovering and moving forward with her TB treatment, and I think the likelihood is she will have this eradicated, and hopefully it will never, come back again.
Any utility before you take her back for reversal, looking for other sources of stricture, like a small bowel follow through type of thing, or a colonoscopy, or versus a gastrograph and enema type of thing? She can't prep obviously because of endoleostomy, but would that help you at all before you go back?
I mean, I think it certainly doesn't hurt. Again, basically related to my lack of familiarity with this disease process. But I think when you think about the pathophysiology, the likelihood that the colon is involved, or the proximal small bowel is involved with negative AFB cultures, and what we have seen so far, I think it's probably pretty low. But of course, you do want to make sure that there is no fibrotic stricture, just right before the area of concern. So I think certainly a small bowel follow through would be warranted. And I'm not really sure about the role of colonic evaluation, just because I don't think colonic TB is nearly as common as ileal TB. Again, this associated with the granulomatous inflammation and the amount of immune related organs in the ileum. But it doesn't hurt, so we probably will get a high peak enema again, just to make sure that we're really not missing anything, given how complicated she is, and with her underlying immunodeficiency, her risk for anastomotic complications. You really just want to make sure that everything is working in your favor.
Excellent.
I
Yes,
have a
hey,
minor
Stephen.
question. Hi, good morning, Radhika. I'm just curious, how did you manage the colonic stump?
I brought it up through the same aperture. She has a BMI of like 18. And I have actually done that. And also then too, if it broke down or anything, it would be right there. But I've actually done that, a few times, maybe about 4 or 5 times. And I've had no issues doing peristomal reversals, typically because it is in, relatively thin Crohn's patients who are perforated, or patients who are cachectic with obstructing cancers. Right colon cancers. And so I feel like that is, a generally easy way to manage that. But that's what I did in her. And I just brought it above the
Yeah.
fat of the skin.
Congratulations. That's exactly what I was getting at. That's how I manage these patients. It's surprisingly easy. You have to mobilize the right colon hepatoflexure perhaps a little bit more than you would otherwise, but it's surprisingly easy to do the ileocolic anastomosis through the small aperture when you take them back. So congratulations.
Thanks, Dr. Halbar. Great point. Well, thanks everyone for joining us. Dr. Smith, thank you so much for getting up early and sharing this incredibly interesting case with us. Congratulations on your management. And we wish her the best as she recovers and gets back for her reversal. For everyone, as a reminder, we meet, Surgery Live meets every Friday with the exception of the first Friday of the month, rotating through all the general surgery subspecialties. Hope you join us next Friday. We'll be right back here talking trauma topic with Dr. Harrington and Asfa of Hillcrest Hospital, talking about damage control laparotomy and the open abdomen. So we'll hear more about that then. Thanks again for joining us, and we'll see you next time on Surgery Live.